Hello, my name is Sarah Dietz and I'm a registered dietitian. Today we will be discussing the nutritional case study of Jane. Jane is a 14-year-old female who is classified as obese based on her BMI for age. She can also be categorized as pre-hypertensive and pre-diabetic. We will focus more on these issues later, but for now we will first discuss the potential etiologies of obesity in teens. Some of these potential causes can be lumped into three categories: environmental, genetic, and behavioral. These types of risk factors are intertwined in their influence on an individual's weight. Each person is affected differently, and each person may have a stronger contributing cause. Environmental risk is based upon the environment in which we are raised. It can be related to our culture, societal norms, food trends and fads, school meals, family characteristics, peer influences, and a whole host of other factors. Genetics are based upon our family lineage, who our parents are in conjunction with their health status. Behavioral risk factors include minimal physical activity and an energy-dense diet. Depending on the individual's diet, they may be deficient in a number of nutrient categories while excessive in many others. Often you see someone who chooses more heavily processed foods, setting the stage for deficiencies in fiber, vitamins, minerals, and protein, and the overconsumption of fat, sodium, and overall calories. It is interesting to compare the role of each in relation to weight status of an individual. When it comes to the comparison of environment and genetics, one individual may live in an obesogenic environment and never have excess weight due to genetics. However, it's noteworthy to mention that genetics may not be as strong as our environment, considering our society becomes more obese, but our genetics have not changed greatly over the years. Each individual patient comes with their own obstacles in regards to weight loss and implementation of new behaviors. The adolescent is no different. It is especially important to remember that they may appear to be an adult, but they are not. The intervention and approach chosen should be based on the individual. Respect should be developed, self-reliance built, concrete messages created, and the adolescent's preferences should be incorporated. An adolescent wants to feel as if their voice is heard and that they have had some power creating their own weight loss goals. The educator needs to develop trust while getting to know the patient. After discussing the patient's health concerns and assessing their intake, one or two goals should be developed that are agreed upon between the educator and the patient. This involvement will help the individual own their own goals and become more motivated for change. To focus more specifically on our case study, it should be mentioned that Jane was previously categorized as overweight. However, she has experienced an increase of 10 to 15 pounds each year for the past 6 years. This has advanced her to above the 95th percentile, per the CDC growth charts. These charts help to measure the growth of her child in comparison to other children of the same age. When plotting on the CDC growth charts, especially to determine weight category in adolescents, you must know their height and weight. Jane is 62 inches or 5'2" and 152.9 pounds. And we use these numbers to calculate BMI, which is a measurement of height versus weight, and it allows you to plot where Jane falls among this graph. As you can see indicated by my dot in the picture, Jane's current BMI places her above the 95th percentile, or obese for her age. The classification of greater than 95th percentile for BMI for age lends evidence to Jane requiring a full medical evaluation. This new classification increases Jane's risk for future chronic diseases such as hypoventilation disorders, bone and joint problems, type 2 diabetes, liver disease, hypertension, and dyslipidemia. Adolescents are also especially susceptible to psychological problems such as body image disturbances and lowered self-esteem. Jane is currently at an age where she will feel more pressure to fit in with her peers and to not stand out in a crowd. Often we think that adolescents have several years before they have to worry about these chronic diseases. However, with the increase of obesity, we are seeing younger children with supposed adult problems. For instance, Jane is already showing signs of being both pre-diabetic and pre-hypertensive. She is at an increased risk for heart disease as well. The pre-diabetic risk is seen in her elevated levels of glucose and hemoglobin A1C, which is a lab that depicts her average glucose levels over the past 2 to 3 months. Genetics are also not on her side, as her father is a type 2 diabetic. The prehypertensive risk is seen within her blood pressure measure of 125/82, as well as her elevated LDL or bad cholesterol levels and her low HDL or good cholesterol levels. When LDL is high, an individual is at risk for plaque building in their arteries. Jane's mother also has a history of hyperlipidemia. Based on Jane's 3-day food record provided within the case study documents, we can see where she has under and over consumed. The nutrients that are consumed in excess further link to the chronic diseases mentioned earlier. For example, the worsening of obesity, hypertension, hyperlipidemia, diabetes, and metabolic syndrome. In comparison, the nutrients that are inadequate also lead towards a whole host of other problems. For example, coronary heart disease, weak bones, irregular heartbeat, personality changes, impaired vision, muscle loss, and fatty liver. This list is not exclusive. Jane currently consumes 2,800 calories on average based on her 3-day food record. When analyzing her 3-day record, MyPlate Super Tracker recommended that she consume 1,600 calories. And in comparison to that, the Institute of Medicine recommends approximately 2,400 calories per day for a female of her age. It is my suggestion that Jane work towards a caloric intake of 1,600 to 2,000 calories per day while following the heart-healthy guidelines of the DASH diet. There is some concern that an initial drop from an average of 2,800 calories to 1,600 would be difficult for Jane to maintain. It is also concerning that with this drop, she would experience more intense feelings of hunger and a development of negative self-imagery. The target goal of 1,600 to 2,000 calories would help facilitate weight loss without Jane feeling that she is isolated from her peers. Along with the reduction in caloric intake, Jane should also start to regularly see a registered dietitian nutritionist. This would be a great opportunity to learn about healthful diets as well as having her weight loss documented within the CDC growth charts. The RDN would be able to gauge Jane's weight loss as well as monitor her intake. Once Jane is able to initiate weight loss and is more confident in her dietary choices, the caloric range may be shrunk. This caloric restriction should be designed to help further her weight loss and create the best impact for health. In addition to caloric restriction, she should also follow the DASH diet plan to emphasize heart health and the prevention of cardiovascular disease and diabetes. This diet plan promotes an increase in fruit and vegetable consumption, categories that are all but missing from the patient's current 3-day meal record. Based on Jane's current health status and diet, there are several interventions that could be employed to create a positive impact. The important thing to remember is starting with only 1 or 2 goals. This will help to avoid overwhelming and frustrating Jane. It is a concern that an intensive intervention may cause Jane to reject suggestions and cause her to resent dietitian appointments. Positive motivational weight loss counseling techniques should be utilized during each session. After initial results and good rapport, we can move forward with more structured weight loss. On this slide, you can see several goals that would be appropriate for Jane. Goals that include dropping below the 85th percentile for BMI for age, exercising at least 60 minutes per day, limiting screen time to less than 2 hours, the consumption of at least 5 fruits and vegetables daily, limiting or avoiding sugar-sweetened beverages, as well as recognizing and avoiding high-fat, high-sugar foods. She should try and limit fast food while emphasizing family meals, and she should start learning how to recognize her hunger cues. Perhaps the most important and overarching goal would be to lower her BMI to less than the 85th percentile. This drop in BMI would substantially lower her risk for future development of chronic diseases. But it is really important to note that choosing only 1 or 2 of these goals at each session or until Jane feels comfortable is very important. Jane and her family, which includes her parents as well as a sister who is 8 and a brother who is 4, will greatly benefit from nonprofit and governmental nutrition assistance programs. It was reported that her parents frequently run out of money each month and often choose fast food as opposed to preparing meals at home. Jane currently eats lunch at school, however, it is unclear as to whether she uses the National School Lunch Program. Based on the limited information provided, it appears that her family would qualify for the school lunch and the breakfast program, providing Jane with 2 nutritional meals that would be at a reduced or at no cost to them. And outside of the school year, the family should also investigate if their community hosts a summer food service program. This would provide meals to Jane and her siblings as they provide meals to children under the age of 18. SNAP is an income-based program that could provide supplemental groceries, helping to further make ends meet for this family. Another program that they could investigate would be WIC. Jane wouldn't qualify, however, her 4-year-old brother would. This would provide additional food for her brother as well as nutrition education for the entire family. If Jane lived in the state of Indiana, they could visit their local Purdue Extension office for continued education and support in becoming more self-reliant and healthy. Local food pantries would also help to ensure that the patient and her family consumed a more balanced diet. These supplemental programs would be able to lessen the financial burden of providing food to a family of 5 while collectively improving their health. Part of this nutritional assessment, we were actually tasked with suggesting menu items for Jane. And on this slide here, you can see your breakfast menu items of day 1, 2, and 3. And they were designed to meet the My Plate guidelines while trying to still incorporate some of Jane's preferences that we noted from the 3-day menu. I also attempted to use different varieties of fruits and vegetables, like fresh, frozen, and canned, to help keep shelf life and cost in mind as well. And then in addition to a variety of fruits and vegetables, I attempted to reuse several items in different meal suggestions. Here you can see across the board that there is chicken breast used. You can also see that there is wild rice as well as salad. So we've tried to mix in different things from each day to reuse these items. And here on the suggested days for dinner, it's kind of the same theme going through there, trying to reuse menu items and trying to incorporate lots of fruits and vegetables at every meal. The same thing could be said about the snacks as well, but something that I wanted to highlight is that these are just my suggestions based off of Jane's 3-day food menu and my ideas for my plate. During these counseling sessions, it's really important to try and incorporate her preferences to make sure that this is a meal plan that works for her. I appreciate your attention and hope that this case study was informative to you. I thank you for your time and I hope you have a great day.